So we're now about to have the next session of this morning about healthcare, bringing back care to healthcare. So I'd like to ask Agnieszka to come up. Thank you very much. So Agnieszka Kolasinski is a psychologist specializing in neuropsychology and psychogerontology. In her research work, she focuses on the potential of new technologies and digital interventions to promote healthy aging and allow older adults to live better quality lives for longer. She's actually employed by the Czech Academy of Sciences, where she holds the role of resistory advocacy and outreach specialist. And thanks to her, we've been developing these set of 21 operational recommendations. Thank you very much.
Thank you very much, Colette, and good morning, everyone. I'm very happy that we are here together to discuss this very important topic. And I am pleased to introduce you to this next thematic session of today's event, during which we will focus on the importance of equitable, holistic, and prevention-oriented healthcare. I'm sure that we are all aware that during the COVID-19 pandemic, we experienced huge backlogs in the healthcare system. And it highlighted the necessity of promoting interprofessional collaboration and integrated care. It put a spotlight on the intersecting psychological, social, and environmental factors determining one's health and well-being. And at the same time, it also pointed to the unequal access to quality healthcare services in our societies. So during this panel, we will reflect on what needs to be done in order to improve accessibility, availability, and quality of healthcare for all. We will look into health inequalities from a gender plus and intersectional perspective, placing special emphasis on the area of mental health. Our invited speakers, whom I will introduce shortly, will share with us some inspiring examples of holistic, patient-centered, and prevention-oriented approach to healthcare. And at the end of the panel, we will try to collectively reflect on how to use those experiences from the COVID-19 pandemic in order to be better prepared for future health emergencies and also for the ongoing social and demographic changes. But before we start, I would like to invite you to listen to two testimonies of persons who experienced the difficulties, the struggle in the area of healthcare system, both from the end of a healthcare worker and a patient.
I am a 32-year-old nurse working in the blood and oncology ward of a hospital in Iceland since 2014. I'm married and I have a daughter. In December 2019, I became pregnant just as I was asked to become the assistant manager of my ward. In the beginning, we didn't know how our patients and pregnant women would handle getting COVID-19, so there was a lot of stress and uncertainty. The workload as an administrator was massive, and there was a constant shortage of staff due to COVID-19. The rules regarding our patients and the quarantine process were constantly changing, which added to my workload. I quickly developed stress-related symptoms because I was working too much while pregnant. I should have cut back on work, but it was impossible as I was the one who was in charge. Eventually, I had to go on sick leave when I was 30 weeks pregnant. I gave birth in September 2020, and it was a traumatic experience. I think COVID-19 added stress to my situation, which made everything worse, and I developed postpartum depression as a result. When my baby was just 1.5 weeks old, I tried to admit myself to a psychiatric ward due to severe sleep deprivation. But pandemic restrictions prevented me from bringing my child, so I decided against it. Instead, I received psychological services at my local healthcare centre, which were fragmented due to COVID-19 related cancellations and delays. Eventually, I gave up.
I'm Sloboda, and I work as an occupational therapist in a nursing home, which means that I work directly with service users in creative workshops, paintings, social games, and other creative work. When we discovered that we had COVID-19 infections, both among service users and employees, our hell began. The real heroes of this pandemic are caregivers and nurses. They bore the heaviest burden. And I remember when relatives were allowed to come, one son came to visit his mother in her room, and he had to wear protective equipment and could not take it longer than 5 minutes. He said, "This is hell." And our nurses were in the same protective gear for 8 hours at a time. We celebrated the Easter 2020 and Labor Day in isolation. And the first group in isolation went out and played music and danced in front of the quarantine fence. And the second group, under complete protective equipment, danced on the other side of the fence because the quarantine had just begun. Great connections and solidarity were created between the workers and the service users who could not see their loved ones for almost 9 months. I was especially glad to get to know my colleagues who do other and harder jobs than me, such as bathing users, changing their clothes, cutting their hair, shaving, and feeding them. The pandemic has positively changed my attitude towards work, colleagues, and service users. I would never change my team.
I would like to also take this opportunity to remind you that if you would like to discover more personal stories and you haven't yet collected your book of narratives, you can do that at the entrance and make yourself familiar with more of the narratives that we collected through all the cycles of the Resistire project. And now, without further ado, I would like to invite a colleague of mine, Federica Rossetti, to give us a brief overview of the results of the Resistire project on the topic of health and long-term care in times of the COVID-19 pandemic. Federica has been working in Resistire as a researcher of the Belgian Institute of Public Health, Scienziano, and I would like to invite her to present the main points of our project.
Thank you. Thank you, Agnieszka. Here you go. So the presentation of today will indeed focus on the results of our research in the topic of health and care. But I would also like to give you some of the policy recommendation that we elaborated based on the results. So we start with one of the main findings of our research was the unequal access to healthcare and health resources. Already the pre-pandemic conditions of healthcare system did not prepare well enough for the crisis, to face the crisis. And what happened during the pandemic was, as a result, the pandemic quickly saturated the healthcare system of most European countries. So, for example, we have witnessed a postponement of services that were not considered urgent and essential, such as services in the area of sexual and reproductive healthcare or trans healthcare. While care was postponed for everyone, our research findings show that groups with intersecting inequalities such as sex and gender or age, socioeconomic status, disability, ethnicity, and so on, faced more barriers than others in accessing quality health services during the crisis. So, for example, women living in a marginalized community, be it low income or rural areas, struggle to receive adequate health treatment. And to know more about the conditions of this group, we should have data on their health and well-being, but these data are still scarce in Europe. One of the health problems that was highly impacted by the pandemic, as we all know, was mental health. And it is well acknowledged that mental health problems have increased with the crisis, especially among specific groups, such as young people. Even before the crisis, unmet need for mental health support was reported to be high, but during the pandemic, this became even worse. And so we saw during the pandemic a combination of two dynamics. So an increased need for mental health support, but on the other hand, a reduction in supply of services for mental health. And in addition to this, the importance of preventive resources, such as green spaces and nature for our mental and physical health, acquired great visibility, especially during the lockdowns, where we were all not be able to freely go outside and thus accessing these green spaces. And what our research has shown is that there was an unequal access to these resources. So, for example, in the most disadvantaged neighborhoods, there were generally less green spaces available. And also another important result was the importance of community care for older adults, for the mental and physical health of this population group, especially for those who were living alone during the lockdowns. And so to bring back care to healthcare, the system should take care not only of the patients, but also of the workers. And healthcare workers, we could say that they become a new vulnerable group because they were disproportionately more likely to be ill, and so because they were more likely to contract the virus, but also to suffer physical and mental health conditions because they had a very heavy workload during the pandemics. And the conditions were particularly difficult for healthcare workers with multiple inequalities, such as sex and ethnicity. So we can, for instance, think about migrant women working as care providers. And lastly, we have also seen that the burden of formal and informal care fell primarily on women, with detrimental consequences for their health and for their life. For example, in the area of work-life balance. So based on these findings, we elaborated a number of recommendations in the form of fact sheets. And specifically now, the recommendation that I'm going to present to you, they come from 3 fact sheets. So the first one on access to health services for vulnerable groups. The second one on mental health support in times of crisis. And the third one on promoting sustainable and resilient long-term care. They are all available on our website, and they are also hanged at the back of the room. So I guess you have seen them, but I invite you to have a look at them once again. So the first recommendation is reconceptualize health and healthcare as holistic. So holistic care is about caring for the whole individual, providing for different needs, so physical, social, mental, sexual needs. This type of care can tackle effectively the challenges of public health emergencies, but also mitigate long-term risks deriving from these challenges, and also meet the demands of an aging society. So to do that, we suggest to strengthen the preventive patient-centered care, and also to promote interprofessional collaboration, so between the different experts working in the healthcare sector and integrated care. So a type of care that comes from the different part of the health system, and it doesn't focus only on acute care, but also on preventive care. So the second recommendation is to give, it's really related to the first one, is to give community healthcare a central role in the healthcare system. So in this way, we can increase the resilience of a healthcare system to alleviate the pressure on the system, especially during the crisis, advance health equity, and respond to specific medical needs of a local population. And in order to implement this recommendation, we suggest to increase the number of community health workers, which are health workers which receive a lower level of formal trainings compared to, for example, nurses or doctors, and they live in the community they serve. So they know very well the needs of the community. We should also strengthen alternative support services for mental health, which are services that are constitute an integral part of a community, and they are generally more accessible and acceptable than more formal services. And lastly, our research has demonstrated the importance of community awareness and solidarity, especially for older people living alone. So, for example, living in a caring neighborhood can really help people with their daily activities. The third recommendation is to support civil society organizations working with vulnerable groups, because these CSOs can help the continuation of help for those in need, as we have also seen in previous panels. And they are able to not only provide timely emergency assistance during a crisis, during in the pandemic, but also they can have a more long-lasting effect, long-lasting support to vulnerable communities. And to make this support concrete, we advocate the enablement of special funding for grassroots organizations and initiatives led by members of vulnerable communities. So it was mentioned already in the previous panels and yesterday as well that we have another fact sheet on transformative fundings. Sorry, that was a slide. Yeah. The fourth recommendation is to create better working conditions for the healthcare workers, which would improve not only their working condition, but also the lives of these frontline workers. And to do that, we have some concrete actions to suggest. One is introducing gender equality plans in hospital, which are a set of actions aimed to promote gender equality within an organization. And we have also another fact sheet on this in the back of the room. For example, there are countries in which these plans are already implemented in hospital, for example, in France. And moreover, equitable wages should be set in the healthcare sector. And lastly, we should value the work of formal and informal care. And last but not least, we recommend to recognize mental health as an integral part of any crisis intervention from the beginning, which would prevent elevated psychological distress on the population and, as a consequence, avoid economic and social burdens. And to concretely implement the recommendation, governments should revise their investments in the mental health sector and prepare comprehensive long-term strategies addressing increased demands in mental health support. Thank you.
Thank you very much, Federica. So now it is time to explore how some of those recommendations can be implemented into practice through the innovative pilot projects that were founded by the Resistire project. I would like to invite on stage Clément Ramet, who will introduce the pilot project Green Spaces as Ecosystems of Care. Clément's practice combines social innovation, action research, and interventions in public space. He splits his time between complex system research at the Open University of Catalonia and urban practice with ACUI, a social innovation collective based in Barcelona. Besides ACUI, he also co-founded the Thelonious Collective, a community of artists moved by critical hope and becoming earthly, a discussion series seeking to reimagine our relationships with the planet Earth. Clément.
Thank you, Aniska. Hi, everyone. So my name is Clément. I represent here ACI, who up until now was a nonprofit based in Barcelona. I'm actually happy to announce we're turning into a workers' cooperative. We just got the transformation approved, which means that we can really embody those values of care in the way that we work, not just informally in how we organize, but even in the very structure of how we work. Today I'll present, can you show the slides? Today I'll present to you, how does this work? This pilot project that we did in Barcelona called Green Spaces as Ecosystems of Care. So it builds upon the really interesting project definition that Claudia wrote maybe a couple of years ago. And I honestly want to give a huge thanks to the whole Resistire team for providing us with this opportunity to explore such an important topic and for their support. You know, Aisha Gül and Nazlı, Elena and Laia, Art, Alain, all the folks from Resistire that traveled to Barcelona for their guidance, for their support, for their encouragement. It's been a roller coaster, this project, but we couldn't have done it without your help and your trust also in our young team. I'm here representing a team of 4. We have Mireia, Ruji, and Leah, who couldn't make it here, but they were huge parts of the project also. So yeah, I'll try to tell you a bit the story of this project. I'll start with the context. This is the park that we worked with, the green space. It's called Parque de la España Industrial. It used to be a textile factory back during the Industrial Revolution. And if you're familiar with Barcelona, it's right next to the main train station of Barcelona, which means that it not only serves the neighborhood, but also folks come in from all over the metro area to come enjoy the park, play sports, meet their community, and so forth. So it's a brilliant, interesting park with a huge diversity and density of uses, even more so since the pandemic, where a lot of activities, for example, dance or yoga or you name it, moved outdoors. And so the local government from the district has a whole team dedicated to, I don't know the word in English. In Spanish, we call it convivencia, as the idea of living together. It's a bit more than coexistence. It's the bonds between people and communities. And it was really interesting for us to talk with them because it felt like their objective was to prevent conflicts. They were really scared that with all these different people sharing space in very different uses, very different profiles, there would be conflicts. And that was their main goal. And I'll come back to this point because it was quite interesting how it triggered a paradigm shift for them. Let's see. So yeah, the biggest thing is the park is so full of life and such a really lively, wonderful place, but obviously with a lot of issues. So we kicked off the project with a phase of action research, which was really important for us to kind of immerse ourselves in the ecosystem. I mean, we were users and neighbors of the park before the project even started. And through the project, we were able to build relationships with these different actors who are really central in the park. These are street educators. Laura, she works with youth. She's kind of like a youth counselor who's based in the middle of the park. And Uriel, he animates a makerspace. And they've all become really precious allies throughout the project. And so this first workshop was to kind of map the ecosystem, understand all the different entities coexisting in the space and their relationships to each other. No, it's not a static map, but rather just seeing how those different entities relate to each other, which also enables us to identify, well, where can we start forming alliances of care? Where do we have leverage within this really complex ecosystem? And so as you can see, I mean, this is just the ecosystem related to care around this park, right? And there's more than 100 entities. So you see the kind of crazy density of actors that we're working with, but also recognizing that the pandemic has taken a huge toll on these initiatives. It's taken obviously a huge toll on human lives, but also it's killed a lot of initiatives. And a lot of them still haven't found the momentum to restart since the pandemic. So the idea there was to reignite a bit this social fabric and the kind of spirit of collaboration and mutual aid that has always been very present, especially in this neighborhood of Barcelona. So walk you a little bit through the activities we did. This was, I would say, a really, really important piece of the project. The queer group that Leah and Mireia facilitated a series of workshops through. And it felt a lot like a Resistire Open Studio, except that it kind of spread through several months. And we consolidated this, you call it Grupo Motor, a group of people that are getting really involved and participating, sharing their feelings of how they feel in this park and public space and so forth. What are their opportunities to exist in this space? One thing that this really opened our eyes on was what we would call the non-users of the park, right? A lot of time the city's focusing on the different users, but who's not there? Who's not occupying the space because they don't feel welcome, because they don't feel safe, because they actually are not safe? And how can we cultivate these cultural shifts in the park for all people to truly feel welcome and included in the space? So this series of workshop yielded so many insights, and more than insights, there was also a group that then kind of kicked into action mode and made a lot of things happen. We'll get back to that. And they're still active, by the way. This is another really key alliance of care that we formed throughout the project. They're called the Xarxa pel Dret a la Cura. That's the network for the right to care. So they're an advocacy group, a network of different entities that work in the care sector, and they're pushing for putting care at the center of the political agenda, the policy agenda at the Spanish national level. So a bit like the Resistere Consortium, but in Spain. And I put this figure here because it's borrowed from them. It really exemplifies this idea of care being a thread throughout our entire life, right? From the moment we're born until we die. And maybe, you know, we're living with the functional diversity or with mental health issues, with the chronic illnesses, whatever our conditions, care is a continuum throughout our life. And they prove to be really precious allies. They put us in touch. I need to run. So this one of maybe the culmination of the pilot project, which was this Cineforum, this open air cinema debate that we organized in the park. And we had 3 sessions that were co-organized and curated together with the different collectives from the park. The first one was with the Queer Collective, and we invited, we showed a movie about a trans youth who grew up in Catalonia and invited them, as well as different protagonists from the documentary and the directors. Had a really interesting debate. The second one invited these women here who work in the care sectors from the Mujeres Unidas Entre Tierras collective of migrant care workers. I had a really also rich debate there. The third session we had was with different local collectives, the skaters, the basketball, who all share a commitment to improving gender equality within their respective practices. And our intention here was to create a space for dialogue, for debate in public space where, you know, we realized we all live in bubbles and society is so polarized. So creating spaces for genuine exchange between very different people. We had quite some conflicts, actually. I mean, pretty heated debates, but that was positive for us because it meant that people can be themselves and be real in public space. This is, let's see if it works. A little video from I'm running out of time. You get but the kind of involvement of different people. The cinema, we had about 100 people every session. People like Rosanna, who was basically one of the participants who really stepped up to help us organize everything. So huge thanks to all those participants who really took a leading role. And Aki was just there to support and create the conditions. So some takeaways and insights. Actually, I brought this little newspaper that I have a stack of them that I'll distribute if you're interested to learn more about the project. This idea of building these long-term relationships with different stakeholders, relationships of trust and of care, which then enables collaborations and kind of mutual aid. And this goes far beyond just the funding horizon. I mean, the pilot project was 7 months, I think, and these different collectives are still working together. You know, they were introduced to the pilot projects. The skaters organized another kind of festival in Sans. Now we have a Latin American collective who contacted us to do another cinema series. The queer group is working on a queer degrowth festival. So we have a whole bunch of different initiatives that were born out of this small pilot project. Another key aspect that Pinar mentioned yesterday, which I thought was very relevant here, is to look at care outside of the domestic sphere. Obviously, care primarily takes place in the domestic sphere, but what do relationships of care look like in public space? How do you care for a neighbor? And kind of a long-term vision or open research question for Aki is, what does a caring city mean? We work a lot with urban praxis, and so working to incorporate care in the municipal agenda, how cities function, but also how bottom-up collectives organize with each other. So yeah, that's that. I wanted to thank again all of you, the participants of the project, folks, for all your great work, and take care. Thank you.
Thank you very much, Clément, for presenting this beautiful multi-level and multi-actor initiative. I would like to remind all of you, even though I'm sure that you've seen that already in the program, that Clément will be joining us for the panel discussion. So if you have any questions, write them down or keep them in mind so that you can ask him after the end of this part of the session. And now for the next pilot project, I would like to invite Aneta Brunerova from Nevypušť duši, who will present a project called CareFair. She works for a Czech nonprofit organization that is not afraid to talk about mental health and knows how to take care of it. There she works as a communications manager, and she's actively involved in reducing the stigma associated with mental health issues and opening up a public debate about mental health. She regularly engages in solidarity projects and is supporting in various forms local community life through organizing public events. Aneta, please.
So hello, everyone. Hope you can hear me well. Yeah, 2 buttons. So thank you so much for the great opportunity to be here with you today in this very inspiring environment. My name is Aneta. I'm here on behalf of a Czech NGO Nevypušť duši, and today I would like to share with you a bit about another one of Resist Erase pilot projects that we have carried out as an organization. The name of the project was CareFair. One of its many outcomes was the CareFair Day. And within these 10 minutes that I have here today, I'm going to talk a bit about both of them. But first, something about us, just briefly. Nevypušť duši, where I work, is an organization that is not afraid to talk about mental health and knows how to take care of it. It always sounds nice when I say it. The 3 pillars of our activities are public education. We organize workshops for children, young people, teachers, as well as companies and the public throughout the whole Czech Republic. Our main weapon is prevention, which we see as the most important tool in the fight against mental illness. And we also show how and where to ask for help when someone needs it. As an introduction to my presentation about the project, I would like to play a short video about the CareFair Day, which is referred to as Soul Care Festival for some reason in the video, so please don't get confused. That's just the thing that the video production company did.
Jménem svých kolegů a celé našeho gymnázia a všechny srdečně vítáme. Dnes se bude realizovat od našeho vydavatelstva mimořádný projekt. Festival péče o duši je vyvrcholením 4. roční spolupráce s mladými lidmi z Uherského gymnázia, kdy naším společným cílem bylo, aby mladí mohli rozhodovat o situacích, které se týkají duševního zdraví a pomoci, a taky přístupu k péči v rámci duševního zdraví sami.
Když vás to trápí a hodně se vám to často opakuje, co vám pomáhá?
Akce je zcela záměrně určená pro mnoho skupin. První z nich jsou samozřejmě děti a mladí. Druhou cílovou skupinou jsou pedagogické sbory a školy, a to i tady z regionu. My jsme se zvali nejenom rumburské, ale i z Ústeckého kraje ostatní školy, a zároveň je pro rodiče. Takže i na škole se nachází mnoho rodičů, nejenom žáků a žákyň, kteří sem dochází, ale také rodiče, kteří sem své děti chtějí třeba dát. A také jsou tu organizace a instituce, které vlastně tu pomoc nějakým způsobem v jednotlivých tématech nabízí. Akce se koná na Rumburském gymnáziu proto, že služby a dostupná pomoc v Ústeckém kraji je výrazně omezena proti jiným regionům. My jsme na začátku měli 17 témat, které zaznívají v terapeutovnách, konzultacích a na krizových intervencích. A spolu s mladými jsme je potom prioritizovali. Vypadly z nich 4 stěžejní témata, kdy jedním z nich je, jak přenášet své požadavky zpátky do školy, jak poprosit pedagogický sbor a školu samotnou o to, aby byla podpůrná nějakým způsobem. Dalším z těch témat je především rodičovské téma. To znamená, že děti poptávají nějaký prostor u svých rodičů a nevědí, jak. A možná ho neumí často ani právě poptat. Zároveň ti rodiči často také neslyší na druhé straně tu poptávku ze strany těch dětí. Tak to jsou ta největší stěžejní témata.
As a scientist or as a researcher, I'm interested to understand the lessons learned. So who was there? What did the students choose? From the higher level perspective is that it inspires others, and that this type of approach is followed by other schools and in other cities and even countries.
So that was a short introduction video to the project, and now I kind of feel like Bara, who is the head of our organization, said it all in the video. So I'm gonna go ahead and talk a bit about the data, which is not only the baseline for the entire CareFair project, but also for our efforts as an organization. So we know from research by such organizations as the WHO, UNICEF, or the Czech National Institute of Mental Health that 1 in 10 children in the world is currently struggling with some form of mental illness, and also that 1 in 5 lives in a family where someone suffers from mental illness. Contrastingly, only a mere 2% of government budgets are allocated to mental health care on average, and there are many barriers attached to seeking help alone. The strongest 3 of which are lack of education on the topic, stigma of seeking help, lack of trust in professionals, and of course, socioeconomic barriers. All in all, we can say that prevention is still not given enough attention on any relevant level, and there are major discrepancies in accessibility of care depending on regions that should and need to be mitigated. This kind of change, we believe, to the extent that we can attempt it, should start in the environment where children spend majority of their time, which is at school. So that's where we placed our project. To even start thinking about the way this change could happen, we needed to know what we are aiming at. So that was important for us because we wanted to make sure that the final outcome actually represents and corresponds to the ideas and requirements of the children, the students. So we asked ourselves a question: how do you find out what a safe school environment open to a debate about mental health without the prejudice and stigma attached to mental illness looks like? We were wondering, how are we going to get the answer? And in the end, we decided to ask the kids. And that was the beginning of our project. In the beginning, there was the selection of the school in which to implement the project. As it was already mentioned in the video, we decided to choose the grammar school in Rumburk, which is probably not a city you would associate with the Czech Republic at first sight. The main reason for us choosing a school in the Ústí nad Labem region in Rumburk was that the access to help is much more scarce there and overall in regions than in big cities. So we can imagine that the project would not have had such an impact in Prague, for example. And also another reason, more personal for us, is that we have run workshops for students and teachers at this particular school in the past. So it was quite a familiar environment for us. After that, we were looking for students and teachers who would later on become the part of the board that was carrying out the whole project. In the end, we had 14 members, 12 students and 2 teachers, and we were working together for 9 months. During the process, we were following a human-centered design method, whose main tool is that it takes into account the wants and the needs of individual or of a group, which allowed us to really involve the children and teachers in the whole process and to make sure that the outcome was in line with their expectations. After many sessions that were methodologically not unlike the open studios that we were talking about here yesterday, actually, we came up with some topics from which we choose the 4 main ones. how to help a friend, how to talk to my parents, how to make our demands heard at school, and also inclusivity and diversity support. So we listened, we remembered those topics, and then translated them into the form of the Care Fair Day itself. The day itself, it was a bliss. It was like very creative. It was funky. Everyone enjoyed it. We included, for example, a wishing wall. We were planting oregano seedlings. Our lecturers, who are mainly students of medicine, psychology, or various helping professions, conducted a total of 9 trial psychotherapies and 18 crisis interventions. We turned one of the rooms into a relaxation zone covered with bubble wrap. We organized a prize game for the children, and we translated the predefined topics into workshops for adults, teachers, and for children themselves. There was also a queer zone, since the topic of diversity resonates very strongly throughout the school, and a space for sharing good practice and information about the current state of mental health care in the Czech Republic. In the end, 450 students and 60 adults attended the event, which hosted 25 workshops and 11 organizations, mainly NGOs, local social services, and low threshold centers. We have set up a purple mailbox for the students into which they can throw their wishes and complaints. And we were also very happy when several of the board members joined the school parliament. And overall, on a more practical note, we can say that the students expanded their competencies in research methods and event management. Now, this is the last page of my presentation that summarizes the final results of the research that we did during the project. We can say that everyone was fairly satisfied with the project itself, with the Care Fair Day. Everyone was excited to be there with us, and we were very, very happy to see that. We managed to intervene in raising the profile and normalizing the topic of mental health. And the best feedback that we got was when the students kept telling us that they really feel that they had been heard and empowered in their confidence and in supporting and caring for those around them and expressing their own views as well. And I have some more data, which I didn't have yesterday because we just finished one of our analyses yesterday, so they are not included in the presentation itself, but I'm going to tell you about them because now we know that the number of students who know that there is someone at school to whom they can actually talk about mental health if they don't feel good has doubled since the festival. We know now that there has been more than a 4-fold increase in the number of students who actually know that there is psychological help available at school. Almost no one knew it when we were beginning with our project. And there was a 3-fold decrease in the number of students who say that mental health is not talked about at their school at all and that it's overlooked. So we are very happy to be witnessing these results. And I was very happy to talk to you about it today. So thank you so much. If you have some questions, you can ask me later on or just contact us. Thank you.
Thank you very much, Aneta, for this inspiring presentation and beautiful example of participatory design. And thank you for giving voice and agency to the students. And now we can move to the third part of this session, to our panel. So I would like to invite back on stage both Aneta and Clément. And also for other speakers that will be contributing to this session, I would like to invite Caroline Coston, Anke Witewin, Hanna Haveri, and Anna Szczegielniak. And I will now introduce briefly each of you. Just please be seated, be comfortable. Okay, so let's start from Caroline. She's a director of EuroHealthNet, the European Partnership for Improving Health, Social Equity and Well-being. She leads a multidisciplinary team working on European Union and subnational policy, research and capacity building, addressing health inequalities and the social determinants of health. Caroline is active in various EU and WHO fora as well as in advisory boards of European projects. And she's a member of the Economy of Wellbeing Expert Group for Finland and of the ICC International Council for the European Public Health Conference. Maybe a round of applause. Anke instead is a psychologist and epidemiologist working as assistant professor at the Department of Clinical Neuro and Developmental Psychology at VU University, Amsterdam. She studies the prevalence, determinants, and neurobiological correlates of common mental disorders in vulnerable populations and conducts trials to assess the effectiveness of CBT-based interventions. She's currently involved in the EU project Respond on the short and long-term mental health effects of the COVID-19 pandemic, and it is one of the sister projects of Resistire. Hanna is a specialist in neurology and has a special competence in e-health. Since 2021, she has worked as a planetary health physician, trying to find new solutions to overcome the three crises of our time: loss of biodiversity, climate change, and public health crisis. She has built a concept of planetary prescriptions together with her working group consisting of environmentalists, biologists, and also experts in nutrition. Her scientific interests are in connections between nature, biodiversity, and health. And last but not least, Anna Szczegielniak, who is a psychiatry specialist, researcher, and clinician at the Medical University of Silesia in Katowice. Her scientific interests oscillate around broadly understood social psychiatry and mental health rehabilitation, public mental health, behavioral addictions, and new technologies, as well as sexual health. She's actively involved in the areas of leadership, gender equity, human rights, and access to health services, with particular emphasis on people at risk of exclusion. She's involved in advocacy for FRIDA and Global Resilience Fund. So once again, I would like to welcome all of you and thank you for joining us today. And as the first question of today's panel, I would like to ask you about your thoughts on the recommendations that were presented earlier by my colleague Federica. So I would like to ask you, based on your experience during the pandemic, how those recommendations relate to your activities. How do they resonate with what you've observed in your practice? And maybe we can start from the right, so from Caroline.
This works? Yes, great. Thanks for the invitation, and it's great to be here. And I would like to start with congratulating you with this project and all of the recommendations. I've been reading the panels at the back, and I must say almost all, if not all topics very much resonate with the work that we do at EuroHealthNet. So maybe a few words about EuroHealthNet. We are a European partnership of national public health institutes, some regional health authorities, but also some ministries of health and universities that are all concerned about reducing health inequalities by mainly working on the underlying determinants of health. And of course, we were very concerned, like you, with the whole COVID situation. Actually, we called it not a pandemic, but a syndemic, following Professor Claire Bambra and also the Lancet. The syndemic says that the COVID diseases and problems have been magnified really by existing inequalities, in the determinants of health. And that is why it's making it syndemic. And it also shows that we need quite a systems response, how we deal with a crisis. That the response that we have seen from the healthcare sector was primarily biomedical responses. And we have been arguing very much from the very start, like what you're also saying here, we need also very much social, psychological responses to the crisis. In addition to the crisis, we also seen that the increase of NCDs has also continued. So we see a lot of obesity among children, for example. 1 out of 3 children in Europe is overweight or is obese. If you look at the type 2 diabetes, that has doubled since the last 2 decades. Air pollution is killing 400,000 people prematurely every year in the EU. So we see this burden of diseases, and we also know that the burden of disease is higher prevalence at people at the lower end of the social gradient. So people already suffering inequalities have this higher disease burden that also impacted, of course, on the severity of NCDs, of COVID. At EuroHealthNet, we are now acting, let's say, at 2 levels. On the one hand, we are embracing more the systems approach to all of this. And secondly, we are also looking at, okay, how can we transform health services so that they are better prepared to face these kind of crises? The first point, the system approach, in that we are embracing the concept of the economy of well-being. I don't know whether you've heard of that. It is a concept that was put forward by Finland in 2019 as one of the council recommendations at the presidency. And the economy of well-being states that economy and well-being are 2 sides of the same coin. So you need to invest in well-being. It's not a cost, but an investment, because it also benefits the economy and the other way around. And there's also the concept of the well-being economy, which is similar, but the well-being economy goes a little bit further, and that states that it recognizes that the current economy and the current way we live unsustainably is causing a lot of problems, and we live unsustainably. And it says that we need to develop the economy in such a way that it is built on a social foundation. It doesn't exploit people, and at the same time, it doesn't exploit the planet and respects the planetary boundaries. This, I'm referring here also to the donut economy model that you may have heard of. It's from Kate Raworth. And looking at how can we design economy in such a way helps us to work upstream and to address all of these factors that lead us to many of the problems that we are facing today and many of the crises that we are facing today. My second point, I will keep it short. My second point is, okay, how can we apply that model to health systems? Because our health systems are also very unsustainable. We read it in the news often. The workforce are struggling. The demand is too high because of the NCDs, because of the aging societies. Also an overconsumption in health services. Research shows it can be up to 30% even. A lot of waste. Health services are also not sustainable in terms of climate. So health services, they need to change, and they need to change towards more preventative services, moving away from repairing and fixing things, but also to see how we can prevent things, and moving away from only hospital systems based, but moving into community, linking not only integrative services within health services, but also integration with social services, with employment services, recognizing that prevention is very much related to how people live and their lifestyles, but it's also about facilitating healthy environments, healthy living environments, making sure that our food systems are sustainable, dealing with the high levels of unprocessed food and so on. So many items that the health system can work on within the health system transformation within, and in the broader systems approach that I just set out.
Thank you very much, Caroline. You touched upon so many important issues. Thank you for bringing this holistic approach and for combining the societal economic and environmental factors that are relevant when it comes to health and well-being. And I think it resonates very well also with work of Hannah. So maybe I will ask her right now to respond to both what you've just heard and to our recommendations.
Well, thank you. I thank you for the first comment. I agree with the recommendations, and I work in a program in Lahti City. I work in the healthcare sector, but we have launched a common program with 3 different organizations: the healthcare sector, and also in the municipalities and the research world with the universities. And we have this common program where we try to think everything holistic. We have the planetary boundaries, and the core idea is how to promote both the well-being of the people, human beings, and also the environment. And in that way, we also get the benefits from the economy as well, and also the benefits for the human health. And we have the same goals in this One Health idea, planetary health idea. And all the recommendations include the recommendations for the human health and as well as the environmental health. But the mental health is very dramatic if we think about COVID pandemics. Also in Finland, we have quite good healthcare system, but it is very burdened. It was already burdened before the COVID pandemics. And when the COVID came, everything was locked down, and we had to think about new ways how to contact our patients and how to contact vulnerable age groups and vulnerable groups as well. And the mental health issue became dramatically pressurized, and we saw that we have to do something differently. And luckily, we had already e-health solutions for many things, and that was very relief for the healthcare sector as well. We had e-appointments, for example. We have digital pathways as well. But everything had to be developed very quickly. But then we also had in Finland, we have the benefit for green environments. Nearly everybody in Finland live at a distance of 300 meters of the nearest attraction or 700 meters distance from nature, because especially in the early pandemics, we saw that people wanted to get help from the nature because every hobby place was closed down and everything was banned, and the adolescents were quite alone what to do. And then we had the green spaces, and every nature path or national parks, they were packed with people. People found the nature again, and that was very, very nice to find out. And even if the mental health problem and mental well-being went down during the COVID pandemics, we also saw some straws of light during the pandemics, because the youth and adolescents, we have feared during the past few years that the nature connectivity is not so good as it used to be in the older age groups. But during the pandemics, the youth found nature again. And nowadays, we saw in the recent study that the adolescents are more active in the nature nowadays than they used to be before the pandemics. And because nature is a very good motivator for physical activation, I think this is a really good straw of life. But we have to think about nature areas, and we have to preserve the areas also in the cities. And if we don't have these green areas, we have to create them with green structures as well. And that is a possibility in the Central European cities, who have already lost all its nearby nature forests also. But in Finland, we have the question as well. We don't have enough quality of the nature areas in all parts of Finland. So that's the question to remain. But we have to remember the force of the nature. There is a good potential to mental well-being as well, as according to many studies during the past decades.
Thank you very much. This is such an important remark, and I think it is very good that we are speaking about it here in public. I remember the beginning of the pandemic in Poland, my country of origin, the first thing that was closed were forests and parks. So it is definitely counterintuitive to what you're saying and how important those spaces are for well-being and health of the population. So maybe I will ask Anke right now to give us a little bit of a background of her research project and tell us about what happened with the mental health of the society during the pandemic.
Yes, thank you. Well, diving into, of course, the RESIST recommendations and solutions and how they relate to our project Response, which also looks at the short and long-term effects of the COVID-19 pandemic on mental health. We are doing and have done several things. First of all, it is important to acknowledge that we have information that comes from a lot of large research projects, and we are trying or are already harmonizing all these data to capture the vulnerable groups as well. And this is, we found out that this is quite difficult. The data up till now is limited in terms of not including enough people from, as you already said, from the lower ends of the socioeconomic status, those most vulnerable, but because it is clear they are affected most by crises like the pandemic. But we want to also pinpoint that, of course, in epidemiological parameters, outcomes, etc. And this is something with our umbrella review we developed with the WHO and published in PLOS Medicine recently. We found out that there's a lot of data on prevalence on the short term during the pandemic, but it's not compared to how it was before the pandemic. And of course, getting a good picture is important in our project. So that is what we are doing, and that's one part. So get a good view on the vulnerable groups and also act on their problems, their mental health problems. In our project, we focus on migrants, labor migrants, refugees, homeless, but also on healthcare workers. We work with 13 partners. We do randomized controlled trials with a stepped care approach. We start with a digitalized digital app of 5 weeks, and it's guided by peers from the same community. For example, the healthcare workers, they go through this first step, these app modules that are based on cognitive behavioral therapy, actually on acceptance and commitment therapy. I'm not sure if you're familiar with that, but it's also based on mindfulness, for example, stress reduction. But they are assisted throughout this process by a peer from their own healthcare community, because this is really important. And this has been developed in close collaboration with the WHO. And after this first step, if they still have a high level of distress, we include those with a high level of distress or high moderate level of distress. So anxiety, depression, maybe PTSD, some symptoms. And then they step up to another level if they still have that after this digital intervention, because you have to make sure that people get enough care, of course, the care they need. And then they get face-to-face CBT consultations, also 5 weeks, 5 sessions, mostly through, in our case, in the Netherlands, in the labor migrants, it is through telemental health. And this is also something I heard throughout the day. This is something we need to incorporate much more in future pandemics, but also now, of course, that that people can get access to care which relates to the level that they need, to the level of symptoms, but also how they can work with these devices, for example, etc. This is also why we adapt all these intervention in each country for each vulnerable population. We adapt them. So these digital interventions, but also this face-to-face intervention, the second step, we adapt them before we implement them. This is very important. Because you have to have the right words, the right way of access, and I think that is something I want to bring also here. That is very important. And just a final remark, if I may, for policy interventions, it's really important that. Governments already or municipalities already start to think of including repeated and systematic data collection, to also include vulnerable groups, to population panels, for example, to capture them already. And in that way, you can also include these digital devices to screen them, to early prevent and to find them and to act on that.
Thank you very much. I can indeed see a lot of points in common between what you've said and what we propose in our recommendations. We also mention how important it is to find a balance between those online interventions and face-to-face interventions. There is no one-fit-all solution. So it is always relevant to keep in mind who we are dealing with and what are the needs of the patients. Anna, from your practice as a psychiatrist, what would you like to share with us with regard to our recommendations?
Actually, I'm always wondering when I'm in that kind of meetings, people with severe mental illness die 10, even 15, or even 20 years earlier than general population. And it's not happening now because of COVID. It's been happening throughout the years. And yeah, we know it. And still, mental health actually comes up usually when there is a crisis. We think about what to do now, how to save the general population. And yeah, and then the crisis stops and we are having a new group with people who are suffering and we are just leaving them there, hoping that maybe there will be something, some other programs that will be a little bit more comprehensive, that will actually take care of the whole health. And I think the population with severe mental illnesses is the unfortunately good population to come up when we discuss those things. Because what I really love about the recommendations is that because they are really comprehensive, they do include mental health and the whole aspect of healthcare services around. But my problem with this is that we already know that, kind of like, it's not a new thing. We know that it has to go beyond a very specific services. But because they are so comprehensive, I think from the practical point of view, they're very challenging to implement because who really gonna do that? Me? I'm usually working from Monday to Friday, 12 hours a day because I work in a hospital, I work at the university, and then I also have ambulatory patients. How am I supposed to host a meeting for the rest of the people that should be involved to make sure that what I do is actually holistic? Putting a bit of burden on the people who are in the services is a little bit challenging, as we saw the burden is already there and the COVID time already showed that. So I think this is a little bit something that we need to think of. While I do agree we need a crisis aspect, services that are actually answering the needs here and now. What we're really missing is how we're gonna really take care in the longer term of people that are actually in need. And there are different vulnerable groups, and I'm speaking mostly because of people with severe mental illness are the group that I'm working mostly with. And yeah, so that's one thing that I was thinking about the recommendation, which I love, but there is always something that is popping up at the back. How are we going to do this? Because, well, it would be great to make this mortality gap a little bit smaller. That would be something that would be really big in terms of the achievements. The second thing is that when I see the shortage of healthcare services providers, and the need to change the quality of work, I'm always scared of how that's going to be interpreted by governments, because sometimes what they do, and what's happening right now in Poland, is that they are just opening the spaces. So they opened like 15 new universities for medical schools. That's great, but where are those people gonna kind of get the knowledge out of. Like if they're opening schools without, for example, in the provinces where there is no mental health at all services. And so I think when we give that kind of recommendations, we need to be very clear, because in the numbers, that's going to add up. They're going to see like, you know, we have the shortage, we don't have a shortage. Done. You know, kind of like things that we definitely need to think of. So yeah, so that's the few things that just popped in my mind when I was just reading.
I can see that Anka, I think, wants to react to that.
This one's working. Yeah. Oh, it is. Yeah. Yes, I think this is a very important point you're stressing here about the lack of people who can provide specialized care, psychiatric care. And I think we have to, if you look at it from a pyramid view, we have to look at the lower parts of the pyramid with a lot of frequency of symptoms, but not severe enough to end up in your room. And we have to have a scalable, accessible interventions delivered by trained people, but they do not need to have, in our case, in our interventions, they do not have to have a background in psychology, or they can be teachers in the background or social workers, and they can be trained in 5 days in our packages that we developed with the WHO. So I think then you prevent earlier on, and this is also what you said already. I think that is important, and you're stressing an important point.
Yes, thank you very much. I think here we come back also to this importance of community involvement. Yes, Hannah, I can see that you also want to add something.
Yes, I'd like to comment to that. I do really agree, because in Finland already our gross domestic product 10% goes to healthcare. So I think there must be some kind of other solutions. Not only healthcare must take the responsibility of the mental health or mental well-being or prevention, and that's why we're trying to launch this program also in our region, in our county. How to get all the other sectors into the work, how to promote healthier lifestyle manners and mental well-being. And we need also organizations and all those citizens into this work. So it has to be in all levels of the society.
Absolutely. And it is also related to the sustainability that you, Anna, mentioned, that we cannot be taking care of mental health or healthcare in general only when there is a crisis. There needs to be a consistent strategy. Speaking of, I would like to move to the second question, even though some of you already partially answered that. But I've been wondering whether you've had a chance to observe in your own work, in your own practice, in your own countries, some positive examples of patient-centered and holistic care. And if there is any example that you would like to share with us right now. I would maybe give the voice to Caroline, if you could pass her the mic. Thank you.
Thanks a lot. Yes, again, I would like to act at two levels. I really would like to argue to look at systems approaches, because we need to make sure that well-being is considered, mental health and well-being considered at the highest level of governments. And that's why I like very much the economy of well-being, which actually started in Finland. And with the systems approach, we mean that we want to have an alignment across all the sectors of government at the horizontal level, but also in a way alignment at the vertical level, so that it's connected what's happening at local level to at the top level and even international level, because many of the challenges that we are facing has an international consequences if you look at climate change and demographic change and so on. So I would like to give some examples at this system level approach. Well, in Finland, they have a national action plan on the economy of well-being, just released this year, which will be interesting to see how that will be further implemented. But if you look in Wales, for example, in Wales, they have a legal act from 2015, and that is to ensure the well-being of future generations act, where public administration across all sectors need to adhere to some common goals. Common goals, let's like a greener Wales, a healthier Wales, a wealthier Wales, and for example, we organized a visit in Wales, and I had a chat with a lady who's in charge of parks. And she said, yes, this act now forces us to really think out of the box, because now with my park, I need to demonstrate how I contribute to better health and well-being. So they have to think how to make use of their parks in different ways so that they comply to that goal. So that is an example, I think, how it is already working well in Wales. If we talk about the prevention in Estonia, for example, they took prevention of problems as a cross-cutting topic across sectors. And this prevention topic was actually started by the Ministry of Justice about preventing crime. And then the Ministry of Justice talked to other sectors, and then the healthcare sector came in talking about prevention. So you can see that prevention is another way how it can connect sectors and avoid the silo and really increase the system thinking. And then if you look at the local level good practices, I think that social prescribing is really a very nice example of how health problems or people experiencing health problems and visiting GPs can be helped differently than in a medicalized ways, because many people do not need a pill or do not need a medical treatment to deal with their problems that are often rooted in isolation or social problems or other problems that they have. And social prescribing means that a GP can then refer the patient, not really patient, the person, to a social worker, for example, who has contacts with other social activities or green activities like nature-based solutions or green prescribing. And I think that is a very nice example, what we have seen in Lisbon and Portugal, but also in Wales, that is happening to connect different local level services to improve mental health and well-being of people. Another example that I thought was nice is actually from the Netherlands, where they connect patients to well-being coaches. For example, patients with overweight, and these well-being coaches can help them with physical activity, with nutrition and diet. And this is paid back, reimbursed by health insurers, because if we want to transform health systems, we have to really look at the financial streams, because at the moment, the more pills, the more medical treatment, the better. I mean, that's the incentive for the medical care sector to work towards. And we have to see how we can think of economic incentives to reward prevention and keep people healthy and promote health and mental health.
Thank you very much. You gave so many beautiful examples of positive experiences, of better stories, if you will, that I think we can maybe right now, given our limited time, move directly to the question of how we can actually translate those best practices, those positive examples into other contexts, because you were speaking about both European and national level initiatives. Let's think about how we can use the lessons learned during the pandemic in order to be better prepared for the upcoming crisis and in order to facilitate the international learning. So how we can translate the experience of Clément, for example, from Barcelona to other national contexts. And here I would maybe start from Hannah, because I can see that she already has the mic, unless you would like to pass it first to someone else and then respond.
Well, first of all, if I think nationally, I think the core idea is to create some kind of pathways for different age groups, for example, so or groups with different problems, some kind of pathways that may continue from the healthcare, but they continue until they are in the plain citizen level, so that people have tools to be active in their own lives, so that they don't need the assistance for example from the healthcare all the time, but they are also active members of the society. And I think organizations they are very important in this picture. But I think these kind of pathways or best practices, or what should they be called, social prescription or green prescriptions, these kind of experiences and experiments should be shared. I don't know, would it be some kind of platform for these kind of experiences, some kind of a channel in the internet, or what would it be? But better sharing of the experiences we have all around the world. I think collaboration in the projects, large projects like Resistere, that's a fine opportunity to share experiences, and I think we need more of this kind of work. Collaboration is the key word.
Thank you very much. Yes, you can pass the microphone to Anke.
Yes. We have the same situation in our project. We are doing trials, and of course, in the end, you want to scale up the whole way people get access to these freely available interventions. They are freely available, but of course, there is funding needed, and in the pathways, how to get that to the vulnerable population, even outside a research project. So I think our challenge is to already think of that. I mean, it's available. There is training. We've just set up a training center in our university for these really accessible, scalable packages for mental health in vulnerable groups. We are trying to scale up by having this center also relating to quality checks on the trainers of trainers, on supervisors. So these basic things, they need to be developed more, I think. So this is an idea for the future, really, for the near future. Yeah.
Thank you very much. And given that you were all speaking quite a lot about this involvement of a broader context of a community healthcare, so that maybe we don't always need medical interventions, I would maybe like to ask Clément and Aneta also what they would recommend, given their experience in the projects that were not medically oriented. Clément, would you like to?
Thank you. I'll keep it brief because so much has been shared already. I think I'll just focus on community resilience, community health. I think yesterday we talked a little bit about the continuum of crises now, and we're entering we're in the midst of the climate crisis and biodiversity crisis, and for that reason, I'm really glad we have someone talking about planetary health here, which is huge. There's already really good solutions in place, like you mentioned, the social prescription or the planetary prescription, which I think are really powerful. From Aki, we see those things as necessary, but also want to talk about the collective aspect of these things, community health, as in healing the bonds in our social fabric that's been so damaged by the pandemic and by these crises we're seeing. If you look at the results of elections all around us, more and more polarization, more and more people closing down on each other, and the response that we're trying to, we're witnessing, and that's not new, it's been around for way longer than the pandemic, but this alienation from oneself, from each other, and from the planet. And what the way we're trying to tackle this triple alienation together is building these communities, is cultivating agency amongst people, right? The sense of agency in their communities through organizing, through mutual aid, through different opportunities for participation, co-creation of public spaces. When people feel like they're involved in shaping their environments, they gain, the sense of belonging, the sense of connection with their neighbors and so forth. So I'll keep it at that. Thanks.
Thank you very much. And I think there is a beautiful link with what Aneta will say right now, I can imagine, because you were speaking about those broke social bonds and the necessity of improving agency. And this is exactly what your project was doing.
Yes, I will keep it very brief and very short, since I feel like everything has already been said by all of you right here. But the thing is that what Clément said about agency is something that is very important for our organization as well. You could see it in the presentation, how important it is for us to give voices to the vulnerable ones. And we know that during the pandemic, children and young people were very vulnerable. And the prevailing feeling that they keep talking to us about is that they are really sorry that their voices haven't been heard at all during the crisis. And I think that's the thing we should focus on together with, and again, I'm gonna just like be repeating myself, prevention, because that is what can keep us away from medical solutions. Very often, we know that prevention is very effective, especially when it comes to children and young people, and that's why we do the job we do. It's on a local level mostly, when we are traveling across the Czech Republic and teaching young people how they can take the agency actually and turn it into something that is going to make their lives better, their well-being better, and telling them that they can always ask for help when they feel like they need it. And also what I would just like to say, it is maybe a bit out of the context, is that when we have the right tools, it's very easy, it's much easier to fight when a crisis comes. And the crisis doesn't have to be a pandemic, right? Like small crises can happen every day, like for each one of us, you know. So that's another layer probably of why prevention for us is that important, and why we believe in that effect. And maybe just the last thing on my mind is that there is a lot of social services that are being neglected and omitted. And of course, they are also kind of stigmatized in a way in the Czech Republic. And we know from a research that we've done like 2 years ago that most of adults, when they find out that their children struggle with some sort of mental health issues, they usually contact just the psychiatrist, the psychologist, or their GP, because they don't actually know that there are more options. So that is also something we should probably focus on, to give more credits to those social services that are here. And sometimes there are better solutions, I mean, depending on the level of the problems that the children are struggling with. Yeah, I think that's it.
Thank you very much. And I know that we ran out of time, but I hope that we can sacrifice 5 minutes of our lunch break, because I would still like to give the opportunity to Anna and Caroline to give their final remarks. We have so many interesting things here to listen to that I wouldn't like to miss on this opportunity. So Anna, if you could please respond.
Yeah, I know we are on time constraints, so that's going to be short. So in my opinion, if you really want to be better prepared for the next crisis, we really need to take good care of the crisis we have, which means that let's stop having projects and services for 1 year. Let's think about 10 years projects, 12 years projects, 15 years projects, so we can actually see whether they work or not. Because after a year, it's nice. We usually have a nice results, but you know, in 2 years, there is nothing that lasts. There's nothing that lasts. So that's one thing. The second thing, especially in the prevention, what I think is that there's been, in a different fields of medicine, there's been tons of different prevention programs, especially in a lifestyle changes. They do not work, or they work very unsatisfying, let's say. So I'm not saying that learning from different fields would give us the answer what works, but at least we will not repeat the same mistakes that already been done in terms of the preventive programs that basically do not work, or they work but only in a, you know, in a hospital environment, and then they are just not continued. So those are two things that I would say like makes sense to look a little bit deeper into it. And the third thing is, I think that it's been a challenge, and it still is, but because in a medical environment, I believe there is a bit of resistance to have other people to tell you what to do and how to organize the treatment and help in general. But our experience from our work is that only if you do take all the considerations and all the comments from the patients, how to organize things, especially how to make them effective, available, how to make them accessible for people. Only then actually it makes sense. And I'm saying it because we had that kind of example. We prepared a very nice project, like seriously, very nice project for our patients with severe mental illnesses during the COVID. Nobody showed, nobody. Like we had like 2 people out of 30, but I think we had 30 places. We had like 2 people. And then we started to talk with the patients. And then we changed almost everything that we planned. And then we had full places for the whole pandemic. So it makes sense. But once again, it also needs to, like, we need to think of how to conduct that kind of assessment and not put everything on the people who are giving the services, because we may just simply not be able to do that. Thank you.
Thank you very much. And yes, I will right now like to listen to Caroline's
Yes,
answer.
I will be extremely brief. I just would like to say that this works. Yes, that I think that the recommendations that you produced are really great. And I think the greatest risk is that they may be forgotten. You know, we may forget all the important lessons that we've learned during COVID. So it's really important to take them forward in our advocacy work. In particular also towards European Union policies and instruments, because many of those recommendations resonate with a policy process. For example, the European Commission just launched a communication on a comprehensive approach to mental health only this month, which is interesting to look at and relate with. But there's also the European Care Strategy on long-term care and on education, childhood care. There is the European Pillar of Social Rights. There's the Recovery and Resilience Funds that we heard. They also fund some of this work, and they fund the beautiful community nursing project in Austria. So yeah, a reminder, and I can say that as EuroHealthNet, we are committed to include your messages in our advocacy work and further liaising with the different EU policy processes and instruments. And I hope that we all do that actually, because that's how we can credibly change the world a bit. Yeah. Thank you.
Thank you very much for this beautiful final message, which I think is also perfectly in line what we were discussing yesterday. As Alan mentioned in his presentation, we were struggling with advocacy in this project, but I do believe with you that this is an indispensable part of research and of our efforts in order to actually make the difference. Now I would like to encourage you to continue the conversation during the lunch break, because unfortunately we ran out of time. But a round of applause for our wonderful panelists.